So prior to surgery, osteoarthritis has a long protocol of of how to manage it, and a lot of that is actually started by the patient's GP. So that would involve the routine things like painkillers and trying to maintain function, which is probably the most important part of the whole process. So things like referrals to physiotherapy, and often advice about having hot and cold compresses on the joints that are affected to try and improve things. Generally, we talk about paracetamol as being the first line, and then the latest guidelines talk about anti-inflammatories topically, so applying a cream onto the affected joint to try and get some pain relief, and ultimately adding in more tablets up to opioids or morphine type medications, which are clearly much stronger. In terms of the non drug or pharmacological methods of treating arthritis, we often talk about exercise and maintaining activity, and that doesn't have to be with physios. A lot of that is just going for a walk and maintaining your walking distance. And certainly from my point of view, when walking distance and function and your ability to do everyday life starts to really deteriorate, that's when I start to think about surgery as to minimize and to prevent that loss of function. Probably the single biggest thing that a patient can do to help with their osteoarthritis is weight loss. And obviously in the initial stages, that's going to help by reducing the pain, which will allow you to walk further and to do more. But ultimately, it's such a valuable thing to do because it will also improve the longevity of your joint and any replaced joints, as well as helping with the surgery and minimizing the risks of blood clots and infections and all of the complications that can arise with obesity around the time of surgery. The final thing that I think is probably worth mentioning is our walking aids and orthotics, things like walking sticks and low impact shoes to try and offload the joints and try and make them more comfortable. I think they're a bit of a mixed bag, and a lot of patients don't like the idea of that they're going to start using walking sticks. Generally, I think if it buys you more time and it makes you more comfortable, it's definitely something worth considering. And it will also get you used to the idea of using a walking aid for a short period after your surgery as well. There's a lot of things that used to be used, things like glucosamine, chondroitin. Acupuncture for a long time actually was approved by the NICE guidelines, and they've all sort of gone out of favor. I think generally a lot of those things, if they work for you, should be encouraged. And I have got a lot of patients recently coming to me with turmeric, which is known to be a natural anti-inflammatory. And if it works for you, whether there is a huge evidence base for it or not, it's certainly worth trying. And I've never recommended a patient stop taking something that was of benefit to them just because there was no evidence to justify it. If it helps with your pain and it delays your surgery, I think it's well worth doing. No. So surgery is very often the end point of osteoarthritis. And I think that's quite right, because surgery is a very effective tool. And certainly operations like total hip replacements are very well recognized to be some of the most efficient operations that we do, both in terms of value for money for the taxpayer, but also the huge improvements of quality of life for patients. I tend to say that a patient has to be assessed holistically, and that includes all aspects of their life, not just the arthritic joint. So, for example, patients might have particular lifestyles that mean that they really want to be sporty and they want to be certain activity levels that they want to maintain, and they're unable to maintain with the current arthritis. And in which case, actually, you might have a slightly lower threshold for surgery. And we know that if you are unable to do the activities you want to do, that might have an effect on your mood. It might cause depression, might cause all sorts of other things. So neglecting those because you're just concentrating on a joint isn't really ideal. And then pragmatically, most people want to know the impact it's going to have on their work. And so having time off from work might not be something they're willing to do at this particular stage in their life. And so that might help us to delay things a little bit. But similarly, they might be of the opinion that they can't do their work because of the way their function is at the moment, and that might be something that pushes them more towards surgery. And again, while we assess all sorts of issues around the comorbidities and the risks of the surgery, and attitudes to exercise and to pain, and all of those things that form part of the overall pattern, the only other one I was going to mention as part of this interview was sleep. The end stage of arthritis really has a big effect on people's ability to sleep. And if you are trying to cope and manage your arthritis in the context of your everyday life anyway, with a really poor night's sleep, it's so difficult. If you ask any new parent what that's like, they'll tell you what it's like. So I think surgery is not always the answer, but it's a really important part of the final pathway for these patients. And I don't think stopping or restricting access to surgery is always the right attitude as well. So I think building on what we've discussed is really the main, probably three things I would really recommend people do. Is firstly to try and minimize their weight. And we know that the evidence is really overwhelming that really reduces the risks of complications after the surgery, literally from blood clots through to infections, through to having ongoing pain, as well as instability symptoms and problems with ligaments and all sorts of things. The other thing that I think is really valuable is optimizing all of the comorbidities. So making sure that that your medications are up to date, that your blood pressure is well controlled, all of any chronic conditions have been well managed. And a lot of my practice is based around what the anaesthetic team and the pre-assessment team suggest as a way of trying to optimize and minimize those risks, because this is elective surgery and we have to bring any modifiable risk factors really tightly under control to make sure that everything runs as smoothly on the day and in that immediate recovery period. And the third thing, the final thing, is mobility. So we've spoken about the importance of physiotherapy, and there's a big movement in the arthroplasty world for prehab. This idea that if you are optimized from a physiotherapy point of view and from a musculoskeletal point of view prior to surgery, it makes the operation itself a little bit easier, but it will also make the recovery much better. And especially around knee replacements, the most sensitive marker of post-operative function and range of motion is actually preoperative function and range of motion. And that again is one of those drivers why the big delays and the big waiting lists over time will start to accumulate harm. We need to get people to their surgery at the right time. And that's a really important part in terms of controlling the final outcome. Absolutely. Exercise is really valuable. And we've spoken about the pain relief, and we've spoken about the options that we have to try and help and control the pain. But I need to be really clear that I think that pain relief is about maintaining function. I would much rather you go on to the next step of the pain ladder and be having more pain relief if it maintains the function and the things you're able to do. And whether that's walking a mile or 2 miles or 3 miles, or being able to complete your physio exercises, the more you're able to do prior to the surgery, the better the final outcome will be. So I think it's really important to say that the post-operative period is incredibly variable, and different patients will experience different initial episodes of swelling, different initial severities of pain, and that will all be dependent initially on the patient, how complex the surgery was, and all sorts of other factors. So it's really difficult to be very specific. However, as a general rule, I tend to tell people that the recovery is on a spectrum. And when I normally follow patients up for the first time is about the 6-week mark, after they've had their wounds reviewed and making sure everything is satisfactory. And at that 6-week mark, we often see patients walking into the clinic room with one stick, and often that stick is just because they're out and about. At that stage, they would have discarded the crutches indoors and maybe using one crutch when they're outside in an environment that they can't control easily. Some people may still be coming in a wheelchair because the distance from the car park to the clinic room is just a little bit too much, and that is okay. And similarly, an increasing number of patients are coming in holding both of their crutches, handing them over, say, I don't need these anymore. And these are the patients that are ready to start driving and ready to be doing everything at that sort of 6-week mark. I think as a rough guide, that's a sort of an appropriate level of what to expect for recovery. And then we know that knee replacements take longer to settle down, and hip replacements tend to improve a little bit faster, and there's a really good evidence base for that. And for a full recovery with minimal swelling at any time, it can take as long as a year, so it can take quite a while. I generally tell patients they can start driving at the 6-week mark. If they're progressing well, they're able to perform an emergency stop and control the car, and obviously they let their insurance company know. And that's a general sort of common rehabilitation plan. But again, the more work you do beforehand, you'll still need to do the work after the surgery, but the recovery is that much quicker and that much faster.